recorded. So, okay, week 8, and I told you I made that matching form. And I really think that if you look at your book and you look at all of the topics, it will literally go with the book. It'll show every little topic in there you need. And it helps you if you just want a quick look. What is intussusception, a quick peek, or what's Hirschsprung's, or, what is phimosis? All of these things are there. And it really, sometimes just seeing it in written form can help you remember. So I did that for you. And of course, I always send you the answer sheets, so if you want to practice, you can. If you don't want to, just look at answers, you can, but it's there for you. So I do it only for 2 classes. That's the respiratory, cardiac, and GI-GU. So this week we'll be going over GI, and we'll be going over GU, chapters 41 and 45. Now, Kaplan Advanced Math Peds A is due. I'll give you a little hint. I do not check Kaplan until A, B, and C are done. So if you don't get it done this week, you're not going to get 10% off, okay? That's a hint, because I have to go into every campus, every student, and look up your grades, okay? So to do that twice when you have 75 students, it is a lot of, so I just do it once. So I'm just telling you. So when you look for it, it's hard to find. There's a regular math, and then there is Kaplan Advanced Math Peds A, and that is the one that you want to do for this. I don't need screenshots. I don't need any of that. Just remember, all questions, even correct questions, you must remediate 1 to 2 minutes, okay? So you do that, you're going to get your full grade. If you get 100, don't remediate, you have a 50. So just take the 1 minute. It's not, I'm not, asking for a lot. I'm not asking for blood, no. Quiz 5 is also by Sunday. You have NCLEX questions due. You have diabetes case study open, and your project is due on Sunday. So if you haven't started your project, please submit it. I have been checking those people who send me even messages, check my paper first, check my this first, that first. And I've been giving input, and students have been turning it around and changing it, because I want to give everybody 100. But you've got to do a certain couple things. So if you don't, I let you know. You change it, you will get your good grades, okay? So that's the key with the project. Many of you have asked me what topic, some of you haven't. As long as it's a pediatric topic, I'm okay. It's better to check, but I understand sometimes you just go ahead and start. That's all right too. Don't worry if you haven't checked with me. So let's do the PowerPoint, and then we do have a Kahoots, and it's a 50-question Kahoots. A lot of concepts in GI and GU, and you'll start to understand, once as we go over this. So GI, GU. So first thing we'll go over is a genital urinary dysfunction. So when you think of, urine, you think of kids, think of urinary tract infections. They hold their urine a lot, or they're wiping themselves from back to front, and they're creating, infections for these children. So the other thing is males that are not circumcised, and the parents don't pull back the foreskin and clean it well every day, they're going to have a buildup of schmegma in there. And it's basically like a petri dish, which grows bacteria. So that can lead also to urinary tract infections. Now, how do you know a kid is a urinary tract infection? Well, you'll know. They're going to be saying that they burn, or you're going to smell a diaper that smells terrible. Even infants, you will smell urine that doesn't smell right. They usually will run the fever or lose appetite, or even vomit once, complain of abdominal pain, which is literally their bladder that's on pain, but they call it abdominal pain. And then of course, any frequency. And a child who that is potty trained and just go to the bathroom all the time, all of a sudden doesn't, there's a reason why. So it's something to look for and to pay attention to. So what do we do for parents and a urinary tract infection? Well, we need to follow this closely because children are being potty trained, especially that toddler age. And these children are a lot of times closing the door. They want to be left alone in privacy, especially that 5-year-old kid out there right now. And he wants to lock the door and watches YouTube videos like everybody else does in the bathroom and have some privacy. He says, Nana, I need my privacy. Well, did he clean properly? Did he clean front to back? It's not as bad for a male than it is a female, but still, those are things that we have to think about. So it is basically washing hands. It is wiping in the proper way. Also, adolescents, and it's something we don't think about. Adolescents, we're going to meet them, they're going to be sexually active, and a lot come in with urinary tract infections. One of the things that we can tell them, and usually it's a good idea not to say it in front of parents, because most girls will say, oh no, I don't have sex, mom. And we understand that probably they could have. So if we tell them to urinate as soon after intercourse, that this helps decrease the chances of urinary tract infections, probably sometimes what they need to do. So we got this fever, we've got this, vomiting once, loss of appetite, something's wrong, smelly urine. What do we do? Well, we're going to do a urine culture and sensitivity. Now, on the last exam, one of the questions talked about infants, 5-week-old, and what is the most accurate way to get a urine specimen. And it is a urinary catheterization. And you're going to say, well, that's really a lot, that you think that it's a little aggressive. Well, let me turn around that scenario. A 5-week-old, do they have any sort of defense against anything except what mom gave them? They haven't started any of their, immunizations yet, 2, 4, 6 months, except for Hep B, and Hep B has nothing to do with urine. So if we don't put them on the correct antibiotic, and it takes 2, 3, 4 different antibiotics, what have we done? We've really depleted the immune system on this child, and they could get extremely sick. It could go to the point of being uroseptic. So getting the catheter in, it doesn't hurt, it's uncomfortable. Have the baby sucking on a pacifier, distracting with mommy at dad. You go clean it good, put it in, get the urine out, and it's done. And we know that when that culture comes up, we know that that is accurate to which antibiotic they should be. It's not going to be any debris from bagging a urine. Now, premature infants, that urinary cath is too big. And the size that they make them is actually the same size as we use for a female calf. It's the same thing as an infant calf. It's an 8 French, okay? They're both the same thing. We can't get those in, those little premature 600-gram infants. So we do something called a suprapubic aspiration. And they put on sterile gloves and they take the area and clean it well. And they just take a needle above the symphysis pubis and put it directly down. And they get a 0.5 ml of urine. And again, it's just like getting a catheterization, but through the abdominal wall. So that is the way that we do it there. And then we could do the percutaneous kidney tap when they're older, seeing if the infections in the kidneys, finding out what debris is in the bladder. And if it's, that's the infective process. We do ultrasounds. If we're finding multiple urinary tract infections and we're finding there's obstruction, we're going to be doing something called avoiding cystourethropography. And that is they put a catheter in the child under an outpatient procedure. They insert a dye and they watch it reflux, whether it's reflux up the ureters or if it reflux one side, both sides, halfway, all the way. And then we can get an idea of what's going on and is the surgical intervention needed. And then IVPs and whatnot, usually those are more kidney stones. Now, renal biopsies, all the stuff with this and the post-op care is going to be very similar to what you see with a cardiac cath, which is you're going to have a dressing on a kidney, a sandbag, you're going to watch it, but bed rest 24 hours. So they can eat, they can drink, they can do the normal things, but they can't get out of bed. They need to keep on bed because let's say that, again, the clot from that kidney opens, we could be bleeding inside the peritoneum, or we could be bleeding or urinating outside on the bed. So we'll be watching for abdominal tenderness, which could be that leaking, or monitoring intake and output. Are the kidneys still making urine? So renal biopsy, they do hurt. Be honest with your child, but they will be pre-medicated for it. Many of them given a little sedation because it is uncomfortable, and we don't want the child to remember that. So I sort of mentioned obstructive uropathy with the voiding cystourethropathy. Now, obstructive uropathy can be, as I said, one side, both sides, partial, complete. And this is basically the urine doesn't come down, or it's so open it keeps going up and down, and from the bladder or the vesicle up the ureters, and then it could go back into the kidneys, and it could cause really bad kidney infections. Once it gets to the bladder, it's not as sterile as it is coming from the kidneys. The kidneys where it really is the most, quote, sterile up there. And if we can find this quickly, we can prevent kidneys from being destroyed by that reflux of that urine going up there and those infections, etc. So it's just a picture. It just shows you different things. Know that the bladder is called a vesicle. It's a vesicle that holds something. It holds urine. And the ureters connect it to the kidneys. And anywhere in there, we could make some sort of, like a vesicoureteral stenosis on partial on the right side, or we could see it going into the kidneys, and then that's hydronephrosis, which means too much water is going up there, or the urine is refluxing in there. Now, nephrotic syndrome, probably one of the most misunderstood diagnoses. Nephrotic syndrome has nothing to do with renal failure. And I'm going to say it again. Nephrotic syndrome has nothing to do with renal failure. It is the body's inability to hold on to protein. So it gets rid of it. It just spews all of your protein out. So what do? You see protein in your urine. It takes it from the blood too, right? So hypoalbuminemia, albumin is protein, okay? Also, one of the side effects is hyperlipidemia, so cholesterol levels will be off the wall. And because now you have a hypotonic type of state in the blood, it's going to push fluid out into the interstitial, and it causes swelling. These children can come in with big swollen eyes, edema everywhere. So it is a massive protein loss coming out in the urine, but it also comes out of the blood. So it's a nice big thing that you can see that can go on here. So how do we take care of nephrotic syndrome? Well, this is another immunosuppressed condition, so it's always look out for infections. Now, because there's swelling everywhere, we know that there's going to be a fluid restriction, salt restriction. Whether it's caused by that or not, it doesn't matter. Because we're holding on fluid, we don't want any other manner of holding on to fluid into that body. So we're going to have salt and fluid restriction. Because you are that one that needs fluid restrictions, your activity is going to have to be adjusted, to make sure that we're not overhydrating during activities. Plus, we need to be careful with these children and fluid balances. Now, one of the reasons why they get loss of appetite is their mouth and tongues and gums swell. It gets edematous. So to put food in there, it hurts. I mean, that's how severe the swelling can go. And these are, it's a syndrome that is there for life. It's nothing you can correct. We give steroids to help this, plus these other nursing care of fluid restriction, salt restriction. And the family really needs to know about it, especially brothers and sisters. So our therapeutic management is to reduce all of that urinary protein coming out. And as I said, that's usually we'll give those steroids in there. we're going to reduce fluid retention, which means we're going to decrease salt and fluids going into the body. And of course, minimize chances of infections. And our nursing goal here is daily weights intake output. We need to see if this child is gaining weight or losing weight, because that manages the amount of edema or swelling in this child. Now, we've heard of rheumatic fever due to by a strep infection, right? Well, this is the second diagnosis, acute glomerulonephritis. Glomerulonephritis is caused by a strep infection, again, that hasn't been treated. So usually you have the strep, the pharyngitis, and it's usually about up to 3 weeks later, all of a sudden you'll start seeing symptoms. And what do you see? Well, glomerulonephritis, you are not going to urinate, so you're holding fluids, you're swelling, edema. With edema is hypertension, right? In the urine, you will see blood and you will see protein that's being excreted also. So prognosis, we need to treat the strep infection, okay? And most of the time when we treat the strep infection, we monitor fluids, watch out for infections in these children. Usually we'll get rid of it right away. Some can go into a chronic disease. So just like anything with GU, and you're talking about gaining fluid or edema, daily weights, intake outputs. Another thing we do on the smaller children is watch abdominal girths to see if we're having fluid also in the peritoneum. Again, low sodium, fluid restriction, and be careful with infections. Very similar to your nephrotic syndrome, both of these, the treatment. Hemolytic uremic syndrome is not really that popular, but it is a GU issue. And basically we see bleeding in different places, and the urine does bleed. I don't ask questions on this, and I do mention it because every now and then you'll see a question on it. So Wilms tumor, we've talked about it before, right? This is a tumor on the kidney or the adrenals, and it is boys, ages 3 to 5, mostly African American, and it's a tumor that gets big in the abdomen, and the biggest thing with the Wilms tumor is to be very careful of not palpating that abdomen, because little pieces can be broken off, and that's how it would metastasize. So we'll remove it. Chemo radiation can be done, or both, but surgical removal, and these kids do well. Renal failure. And, I wish that kids didn't have renal failure, and I wish that they didn't have to go to the hospital 3-4 days a week and get, the dialysis, but many children do. And I didn't realize how many children until I was doing some clinicals for another university, and they positioned me on the GU floor. Now, I worked on many other floors, but I had never worked up on the GU floor. It was diabetes and GU, that was on that floor. And they did have the kidney dialysis room, and it was full all the time. So I asked, why are children with renal failure? Well, it could be that obstruction that caused the failure, congenital something born. But what they told me is that these children with chronic renal failure, there was something about the familiar, that some of these families were doing intermarriages in some cultures, and that caused the genes to attack the kidney, and the kidneys didn't work as well. And it's just because of that sort of marriage that was going on. Now, acute renal failure is something that happens, we don't know why, but it could be due to something. I had a friend who actually went into acute renal failure by taking Motrin, but took it a little bit more frequent than normal, like every 4 hours, not every 6. And he had a kidney stone. And all of a sudden he stopped urinating. And his BUN and creatinine went to the point where he was just about to get a catheter and have dialysis. and all of a sudden he started urinating, and they determined at that time it was the ibuprofen. So what do you see in acute renal failure? Well, you stop urinating, okay? In children, the one thing that you've heard me always talk about, keep the children hydrated, because dehydration is one of the biggest reasons why children go in acute renal failure. So dehydration in children should be prevented. That's why children should always be drinking outside, when sports, etc., to keep themselves hydrated. Chronic renal failure, as I said, it could be due to, that some sort of anatomical where the reflux kills the kidneys. And they basically will, during time, if we don't know it immediately, it can occur to be destroying those kidneys. And they call this uremia. So chronic renal failure is that malformations, like I said, vesicoureteral reflux is going up and down from the bladder up into the ureters. As I said, hereditary could be caused by that. Chronic infections, and even lupus, and this anaphylactoid purpura, where it goes in and during, this anaphylactic episode that it does attack the kidneys. So what do? You have a child who has chronic renal failure. Well, we know that we've got to have that kidney working some way, whether it's dialysis with hemodialysis, or is it peritoneal dialysis? And peritoneal dialysis today is becoming more popular even in the adult world. They used to just do it on the small children, but now they're doing it more on the adults because they found that it gives this adult more freedom than, again, going to a kidney center 2, 3, 4 times a week. So what do we want? Well, we want to maintain fluid and electrolyte balances. And you think of kidneys, you always think of high potassiums, right? Always. Another thing you always think of is their hemoglobin hematocrit is always low because they're not producing enough. So these are children that we would get erythropoietin to. And what is erythropoietin? It's an injection that's given that stimulates the own body to produce red blood cells so it can be used and maybe prevent a blood transfusion, which would be better. And again, these kids are already tied down to something, whether at nighttime or during the day, to have their kidneys work. Try to let them be as normal as they possibly can. Now, this is a picture of peritoneal dialysis. Now, infants, because of the way that they are and their heads have vessels in there and they're very fragile, that pressure of hemodialysis creates a turbulence, a flow, and could make those vessels in the brain hemorrhage. So then you have intraventricular hemorrhages, which causes a boatload of other problems. So that's why we have to do peritoneal dialysis. So what is peritoneal dialysis? There's a catheter that goes into the peritoneum, and we connect a tube to that, and we insert warmed type of colloids or crystallites or some sort of liquid that the nephrologist orders into the abdomen. Let's say it's 100 ml, you insert it. And then it sits, or called a still. Maybe it's 30 minutes, it sits there. And then they call it a drain, and it will drain for another 20 minutes. Now, usually peritoneal dialysis is done at night. It's on a machine. It functions independently by itself. So it's running constantly. And these, of course, keep those children, free during the day, and infants that they're not tied to it. Now, at the end of the night, they've had either 8 or 10 cycles of fluid in, sitting, and draining. There are 8 to 10 of those. When you take the amount of fluid put in, and then it goes into a Foley catheter, and you measure the Foley catheter, the difference in fluid is your output. So they do actually put out quite a bit of urine. So the abdomen is what filtrates, the kidneys and gets out, the toxins that we want to do. As again, it should be warmed. Now, the biggest problem with peritoneal dialysis is infection, peritonitis. Now, how would you know there's peritonitis in an infant? They can't tell you, right? Well, what if you saw a different color of fluid coming out that tube in the drain? If you saw it cloudy, you saw streaks of things, it was darker, something's going on, or there's redness around the site, or tenderness in that abdomen, fever, first priority, call the doctor, because immediately we need to get these children on antibiotics, because what's going to work for the kidney if you don't have the belly? If you don't have a peritoneum, how are you going to, take care of your kidney? So we need to protect that abdomen as much as possible. I had a girlfriend started on peritoneal dialysis, and she's a nurse, okay? And she even had troubles trying to remember what step to do next in sterile procedure to prevent peritonitis. And she did something wrong when she first got it in, and she had to go in and get multiple antibiotics just to protect her from possibilities of infection. So it works great. It's a great tool to use. I've seen patients, children, that parents have done it and probably put dressings on better than me. And I'm pretty OCD with dressings, neat and tidy. And the child, was always with lotion on because they have dry skin. And this kid actually went for a kidney transplant finally and did well. But peritoneal dialysis kept him alive, which was awesome. So what best describes acute glomerulonephritis? What did I tell you?
B.
Was it B?
Yes, it's because of the streptococcal infection, yes. Okay, so GI, a lot of stuff in GI, okay? I mean, we can think of GI, we just think of cystic fibrosis, and we know there's problems with the GI tract and absorption and nutrition. So nutrition, we always think about when we think of GI. It's all absorbed through the GI tract. Mouth to anus, this is all where we absorb foods so that we can use it so that we can grow and be healthy. Now, there's going to be vitamin imbalances, mineral imbalances, and if we're not getting as much as we need, as almost a failure to thrive or not enough, nutrition, you're going to have this, they're not going to be as big as they should be, so it could be due to that failure to thrive syndrome, but it usually is due to something else. They could have cancer, they could have HIV, sickle cell nutrition, cystic fibrosis. I mean, I've already mentioned that. And of course, if they're coming in with a low birth weight. So food allergies. Now, infants are in the first 6 months of life, just get breast milk or iron fortified formula. It doesn't mean that they can't be allergic to the formula they're taking. Sometimes when you see a child with an allergy, you might see a rash as prominent as this one in the picture. Sometimes you might see it like in spaces that are a little bit warmer, like under the neck, under the arms, bends of the elbow, under the back of the knees, you might see a little bit of rashes. And that might be all that you see. In the formula or the even breast milk that mom's eating something they don't like, you might see that vomiting or diarrhea, but food allergies, you'll see a little bit different exposure to it. And that's why when we start feeding these infants at 6 months, we wait at least 3 to 4 days in between each new food. So GI dysfunction, growth failure. Why is there growth failure? Well, how many children do you know have reflux and are constantly spitting up and they're constantly vomiting and they're losing nutrition that way, aren't they? It could be due to vomiting, diarrhea, even constipation can cause some problems GI tract. Abdominal pain, jaundice, dysphagia, difficulty swallowing. Remember, mouth to anus. So that dysphagia, dysfunctional swallowing could be part of that. And children with fevers don't eat. They just don't. They don't want to eat. As I said, dehydration is a big thing in children and we want to prevent it. Now, I love this picture of this infant. I look at this picture and yes, you see that fontanelle sunken. One of the things that when you see an infant come in, if they're being held in the mother's arms, they're calm, even if they're sitting straight up, they fontanelle should never be sunken like this one. But beyond that, do you see the color of that infant? Pale. You're going to see poor capillary refill. You know, you're going to see those dry mucous membranes, no urine output, all of those things, elevated heart rate, lower blood pressure, that goes along with it. But I can say the color and that fontanelle, it's a clue right there. You can tell what's happening. So dehydration could be due to many things. It could be due to, you know, they're sweating, which, you know, if they're out playing sports, or it could be due to fever. It could be that they're urinating too much for whatever reason, vomiting, diarrhea, ketoacidosis, diabetes, right? And then burns. Whenever you have burns, it does, you know, tend to destroy tissue and a lot of the fluid. So how do we measure intake and output? Well, we know that there's urines and stools. If we can catch the vomit, okay, but if not, we can guesstimate, you know, small, medium, large, maybe a teaspoon. Sweating, we can also see profusely sweating. And if it becomes a problem where you really need to watch this output even closer, we might put pads underneath this child to try to figure out how much weight of urine came out to determine what the output was. Because whatever you have there, whether it's a diaper or a pad, you weigh it before you put it on the child. We know type 1 diapers are 30 grams. We know if it's then 60 grams, then we know that child had 30 mLs of fluid. Same thing with the pad. If it weighed 200, now it's 250, we know there's 50 mLs of urine. And that's with anything you put underneath a kid. So we can measure actually pretty closely. Vital signs tell us a lot. You know, we can look at that heart rate, and that's why you've gotten those vital sign sheets to know that if you have a 1-year-old and the heart rate's 140, it's a little bit too high. Does the patient have a fever? Or is the child dehydrated? Skin turgor, mucous membranes, capillary refills, urine output. And then of course, if we're doing weights, probably the weight will be low. That fontanelle is a big clue in infants. We could see swelling in hydrocephalus, and then that sunken one at rest, not crying, nothing, just sitting there, be really depressed. And older children get to be a little bit almost like lethargic, you know, they're hard to arouse because they're so dehydrated, because we're not getting, you know, oxygen to the brain. Now, 2 things that happen with children are diarrhea and vomiting. And how do we treat these sort of things in children? Well, with diarrhea, you should feed the child. If you just give fluid, what's going to come out the other end? Fluid. So it's going to continue diarrhea. Now, that used to be years ago, they called it the brat diet. We don't do that anymore. We just say non-spicy foods, bland, and we want to give small amounts. We try them first with, of course, those electrolyte solutions, whether Pedialyte, Gatorade, Powerade, any of them. Whatever fluid we give should include those electrolytes in it. It's a better choice. Now, if a child is so lethargic and can't eat, we will, or if severely dehydrated and we need to get that kid hydrated quickly, we will give IV rehydration. But most 9 times out of 10, we will be, for diarrhea, we will be giving them fluids, probably giving them some sort of probiotic, which is all you do, and start to feed them. And then, of course, go slowly with the introduction of their diet. Now, constipation in children, you think, well, it's just with fluid or this or that. Well, I've seen many children who can hold their bowels for up to, I think the most I saw was 12 days. 12 days and no stool, yes. there were things going on in the house and it upset the child. So to get attention, this child held their bowels so that they would now be the center of attention. And they do that, okay? So children should have several stools a day and it should be soft. And if it's not, need to find out why. If it's that emotional thing, okay, then we can understand it. We can talk about it, let the child, express their feelings right. But there is sometimes reasons that cause it. And then if it's not that emotional thing, then we need to find out if it's something else that we need to treat. Now, newborns should stool almost immediately after birth. And it's usually this meconium, this sticky, gooey, sort of black and green looking stool. That's meconium. It's what it looks like. So in the first day, day and a half, they should stool. If they don't, number one, is it thyroid disease is one of them. It could be that there's some sort of narrowing or not opening going to the rectum, to the anus, and they don't stool at all. Hirschsprung's disease is, we're going to go into that. It's just there's no nerves there, so it's not pushing the stool down. And then, of course, there could be cystic fibrosis. So there are some conditions that we may be alerted to just because this infant didn't stool. Constipation many times can be due to diet. So we need to look at that. Usually, children who are breastfed tend to have multiple stools a day. The formula-fed infants tend to have more issues. And physicians might say, well, give them a little this juice or that juice. They prefer not to give medicines or enemas or suppositories. They try to do it in a more natural way to get them stooling. Now, Hirschsprung's, I mentioned that. It's one of these that you don't have a stool. Now, if you look at this, this is the, ascending, transverse and descending large bowel, the colon, okay? And the bottom of that is where the anus is, where the rectum is, okay? Now, this big outpatching, what happens is there's no nerves. It's called aganglionic, which means no nerves. The ganglions are nerves. So there's no nerves there, so there's no peristalsis. They don't feel pain. So all of the stools or contents tend to build up, get bigger and bigger and bigger. They don't feel it. They don't feel pain. These new infants, brand new infants. But you might see, because of that little tiny little opening in the rectum, some little bit of ribbon stools might be able to get out. It's not normal for infants to have little tiny ribbon-like stools. So if you see it again, it could be Hirschsprung's. So how do we go and how do we diagnose this? Well, the first thing we do is we're going to do a barium enema, and we're going to be putting barium up, their rectum and looking at their bowels, and we're going to be able to see it. Then once we determine, probably we're going to go do a biopsy. And once that biopsy is confirmed, what they do is remove that aganglionic portion of the bowel. It's dead. It doesn't work. It needs to be gone. They will initially give this child a colostomy. And the colostomy will be there temporary. Could be 2, 3, 4 months, depending on the surgeon when they feel, and then they'll reconnect it later. So this requires a lot of care from the parents, a lot of teaching from nurses. Now, I think the most common thing that we do as children, as infant, is vomit. They always spit up, or you pick them up too quick and they vomit all over you. That's why we always have a spit burp rag on, to protect it. So vomiting is anything that comes out through the mouth. Now, if we are having a child who is vomiting a lot, and you could see that they appear to be becoming dehydrated, we might see, that decreased urine output. We're going to see elevated heart rate. We'll see a low blood pressure. Vomiting requires IV fluid. Do not give a kid who's actively vomiting anything by mouth, because what's going to happen? they're going to vomit it up. And we don't want to continue that vomiting. And remember, with the signs of dehydration, and especially with vomiting, please do that metabolic profile. Look at those electrolytes. We're worried about that potassium. Has the potassium gotten too low? Remember, whenever you bolus fluids, never ever use dextrose. Only plain normal saline. You don't want to give a bolus of sugar on a normal child because all you'll do is elevate that blood sugar. Now, gastroesophageal reflux is basically a child eats, it goes into his stomach, and all of a sudden the food goes up and down the esophagus. Infants, you can feel them arching their back and you could feel them refluxing. It's they'll arch and their heads will go back and you'll see them with the arms and legs, little infants, and they're basically telling you that they are refluxing. Now, older children can have reflux and they can tell you they feel that burning and hurt, but sometimes they don't know how to describe it. They're going to have this chronic cough, which means that food's coming up and aspirating, right? Little aspirations into the lungs. So you hear these little cough. You might see abdominal pain and heartburn, but you might just only see that little cough, which could be that clue we need some medicine to help hold that food down. Now, sometimes it doesn't happen a lot, but it does happen where this child is chronically refluxing, chronically aspirating food, really hurting those lungs with damaging it with all of this food going into the lungs. They'll do something called a Nissan fundal plication. Now, that picture there that's showing you, it's the top of the stomach, it's peeled up and it's put up against the esophagus. And what it does, it prevents food from going up. It's like a pinch, so it can't go up. So what you've done is you've kept the food down. These children should not vomit. This is what we do when we put a gastrostomy tube in. Because what do we do with gastrostomy tubes? We just take 200, 400, whatever mLs, and we just pour it down. It goes in the stomach, okay? If they have this fundal plication, the food will not go up the esophagus. If we do the fundal plication, it's better. If they don't, they're going to have, again, chronic aspiration. So the Nissan fundal plication is used for reflux, and it's used in conjunction with a gastrostomy tube. Again, both to prevent reflux into the lungs. Appendicitis. It doesn't matter if it's kids or adults, appendicitis is an appendicitis. It's that connection between the large intestines and small intestines. And it's, the appendix is this little thing that's sitting there, doesn't do much, okay? And it causes pain. So same thing, McBurney point, right lower quadrant. You'll see children, if they come in and they're walking, they'll be bent over a little bit to the right, holding their right upper leg, and they will limp. And you're like, that looks like an appendix. You can sort of tell, and you can tell these children, they really, really hurt. Now, hopefully, this child told the parents soon enough, and the parents also got the child to the doctor or to the emergency room quick enough so that we can do the surgery, and it's laparoscopic. The child's usually sent home the next day, and kid does well. Now, what happens if that appendix ruptures? Well, if that appendix ruptures, the intestines is all inflamed. It is angry. It's upset because all of this debris and all this toxic material has gone all over the intestines. So first of all, nothing to eat or drink, and an NG tube needs to be put down. Because it's so inflamed and angry, that has all this extra secretions, the NG tube is on low intermittent suction to get rid of all that extra secretions. These children will be on antibiotics, IV fluids. but they still get all the same post-op care as any other abdominal surgery. Out of bed, walking out of bed, monitor bowel sounds, monitor stools, but it takes a little bit longer on these children. And of course, use pain management as needed. Now, Meccal Diverticulum. Think of this little flap that comes off of the inside tissue inside the intestines. Usually, these could be anywhere from the small to large intestines, depending. Now, this little flap breaks off or tears, and they have a blood vessel inside. So what happens? It bleeds inside the intestines. So what is the big symptoms? You see painless rectal bleeding. So painless red blood is coming out of the rectum, okay? But they don't feel it. Their tummies don't hurt or anything. So what needs to be done? Well, they need to evaluate it, diagnose it, and they need to go in and remove this, what they call this diverticulum, this little patch of skin with a vessel inside, because they can bleed in quite a few children. IBS, mouth to anus, anywhere where there is pain, inflammatory bowel disease, okay? It could be in segments like ulcerative colitis, Crohn's, and we know IBS is treated with diet, and it's also treated with steroids as needed. And as long as we are, these children are fed properly, these children usually won't have, a lot of discomfort. It's when they, go away from their normal diets that they hurt. Peptic ulcers in children. Children do become little worrywarts, and they do get stressed for many different reasons, and they do get ulcers. Now, I've never seen one that went to the point of needing surgery. Usually, they have to be put on something like a Zantac or any of the other sort of GI stomach medicines. Same thing as adults, smaller doses, okay? Treated by diet and treated with medicines. Hepatic disorders, could be done for whatever reason. You can get, this hepatitis. Now, hepatitis, we do give the Hep B at birth to try to prevent it. So we have a child, let's say got older, and we just find that this child does have hepatitis. We need to know how to take care for that child. Well, these children need to have a diet high in protein, high in carbohydrate, but low in fat, because it causes a lot of gas. And then it causes distension and it hurts really bad. So high in protein, high in carbohydrates, because the protein helps with muscle wasting, and then the carbohydrates give them the energy they need. Now, as I said, GI is mouth to anus, right? Well, here's the mouth. Cleft lip. Now, cleft lips happen, and we don't know why. Just part of the development, all of a sudden it doesn't close up, and the child could have one side, both sides. It could be just the lip, or it could be lip and the palate. So it all depends. I've actually seen the lip fine and a whole palate gone. So who knows why? So how do we treat these children? Well, these children, the biggest problem when they have this cleft lip is, how do they suck? How do they de-stress? They like to suck on a pacifier, right? They can't, because they can't put their lips around them. So this is our biggest thing. How are we going to take care of this child so that they can comfort themselves with their own pacifier? So we try to fix these lips as soon as we can. So lips, we do about 2 to 3 months of age, and they really have to make sure those lips and they're approximated really good, because you can see if they're a little crooked. Now, this little metal thing is called a Logan bar, and what it does, it prevents the child from going there and constantly bothering the scar, so the scar is minimal, because they do real plastic closures on these children. Now, the palate is another complication. Now, the problem with the palate is that when you feed these children, there's nothing to hold it from going up the nose. I had a child in one of the clinical sites where he had a lip, but he didn't have the palate. And as an infant, to feed him, you really had to go slow because the milk would come right out of his nose. Now, they don't do the palate till later on, between 6 to 12 months, okay? The problem with the palate not getting done any quicker is these children want to talk. And because the palate's not there, they talk like that because they can't, make the sounds the way that they should. So speech is huge. So the quickest we can get it fixed, the better it is for the child. Now, as I said, we have issues with sucking. Sucking just to go on a pacifier. Well, what if they are breastfeeding? How are they going to suck a breast? Now, it takes a lot of patience on a mother who wants to breastfeed. She's literally squeezing her breast as the child's there because they can't get enough suck to get it out themselves. If you look at this bottle here, that top is soft and it's very pliable. And you turn the bottle over and the milk goes in it. And slowly, as they're sucking, you will slowly squeeze that bottle and it drips in their mouth so that they can get the feeling like they're sucking, swallowing, and breathing, which is what they want to do so bad. So it's a big thing, feeding these children with cleft lip, cleft palate, and giving them that oral satisfaction that they do need. Problem is, if we don't give them enough food, what happens? Of course, growth failure, cognitive delays, and we don't want that. Now, esophageal atresia. Well, esophageal, esophagus, atresia means a without. Oh, the esophagus does not attach to the stomach. Okay, it's the tube, it doesn't connect. So many of these have a tracheal esophageal fistula or an irregular opening between the trachea and the esophagus. So if we would eat, food goes down the esophagus, it would go across the fistula and it would go into the lungs. So first priority, nothing to eat or drink. Okay, and trying to keep that mouth as clean as we can because we don't want them swallowing all of their secretions. I mean, sometimes we don't know this initially, but what we will see is a newborn infant bubbling at the mouth, and you'll hear them coughing, and they can't take their secretions. They can't tolerate them. So as you can see, if this has this fistula there, no openings, we have a problem with number one, nutrition, and we have a problem, number one priority is respiratory. So we really need to monitor their lungs and keep the aspiration from going there. So they will do surgery to these children. They usually are normal children, and they usually wait a little bit till they're older. In the meantime, they will feed them. They usually put in a gastrostomy tube because that's a tube in the stomach. So they're getting their food until they can get up here and they can do the surgical repair as they need to. These children are constantly having many little aspirations into their lungs, as you can imagine, right? So if they're always getting these aspirations, these children will be on intravenous fluids and they'll be on antibiotics because they're constantly aspirating. We don't want them to get, these big infections. Hernias. Have you ever seen the little umbilical hernia sticking out? You just want to put your finger in. It goes in and out really soft on these little umbilical ones. Usually they're like that. And that means your hernia, it's not a nice thing, but it's not in danger. When you push that and they scream, it hurts, or it's hard red, that is when it's called incarcerated or strangulated, and it needs immediately surgery to be able to, get it off and out of, the wall, whether it's inguinal, whether it's umbilical, wherever it's at. So the big thing is monitoring these hernias for it to be strangulated. Now, one of the biggest hernias that we get is called a diaphragmatic hernia. These are the diaphragm doesn't completely go across the whole belly, okay, underneath the lungs. It's not there. So what happens? The intestines go up into the chest. So your left lung is non-existent and your right lung is being pushed over. So how much area do you have to breathe? Not much. These children are very sick at birth. They're very hard to oxygenate, but they can do surgery, pull down the intestines, and then they really are going to live on one lung for the rest of their life. So this child's going to need aggressive pulmonary care for life. Now, one of the things that infants do somewhere between 3 weeks and 3 months is they have something called a hypertrophic pyloric stenosis. So if we knew the anatomy of the stomach, we know that at the area where it connects with the small intestines, there is a valve called a pyloric valve. Well, this gets small and it gets thickened and the muscular thickened that it doesn't allow food to go into the intestines. So the belly gets bigger and bigger. And all of a sudden, these children will vomit like the exorcist and will vomit forcefully across the room. 10 feet away, you'll get hit. I mean, it is out the mouth into the floor. So when I get an infant in and they're telling me they're vomiting, I'll ask, does it dribble or does it come out? And if they tell me it's going out, I say, well, how far? They go, oh, pretty far. The next thing I will do is fill the belly right about the upper midline area, and I will be able to feel that thickened pyloric valve. It's like the size of an olive, and you could actually feel it there. So what do? Well, if they're eating, they're vomiting. Okay, so this kid is hungry, hasn't eaten. I mean, all the food is going out. So they're irritable, they're hungry. But we will make them NPO. We will start them IVs, and of course, we'll check those electrolytes. And this child will get an ultrasound, determine it's a pyloric stenosis, go to surgery, and these children actually do really well. What they do is they just open up that valve, and these kids the next day, they are getting clear liquids, and they're going home within 2 days. Now, they also will give those children some antibiotics because of the vomiting and the chances for aspiration. So intussusception, very interesting diagnosis. This is when your intestines just takes and goes inside the other one, like a telescope, right? The ones that the pirates use, they go in and they go out. Now, what you will see with this, you'll see this child, the youngest I've ever seen was 5 months, very rare. Usually it's that 2 to 3 area that you see most of them. These children, boys, girls, doesn't matter. They'll come in and you will see them screaming. You will see their arms and their legs just kicking. And if you try to touch their abdomen, it'll be tense, okay? And you're like, this looks like intussusception. So we will send them for an ultrasound to find it. Now, what happens more times than not, all of a sudden this intussusception comes back out and it's gone. How would we know? All of a sudden the kid's not crying, is acting normal, playing normal. It was ready. Okay, we're ready for ultrasound. You're like, nope, they're not going yet. We will wait again to see if it happens again, you know, to try to get it when it's there. Now, usually these kids resolve by themselves, will increase the fiber in their diet, and they do well. Sometimes this intussusception has been there too long, it's swollen, it can't come out by itself. And sometimes they need to do either a radiological procedure where they do an air enema, the radiologist, They put air up into the rectum, they pump it up under fluoroscopy, and they watch it pop out. It's literally just pops it off the end. Now, sometimes that doesn't work, or it's too uncomfortable for the child. And at that point, they'll take them to surgery and they'll have to take out a piece of intestines on this one. So it could be a simple home, more fiber, or it could be surgery. Malrotation and volvulus are basically when your intestines tend to do something. Usually the malrotation is during the embryological development. The volvulus is sometimes, later on. But it's basically your intestines tend to twist around something or twist onto itself, or like in a knot. And you will see those symptoms of, intestines that's not flowing. So it can't go down. So severe pain, it can rupture, it can cause peritonitis. So this is a serious thing. Again, very difficult to diagnose. This is another ultrasound that we would do. Now, you were told in OB that at birth to do a rectal temperature on your infant. You're also told that it's done because you want an accurate temperature. Well, the other reason, there's something called an imperforated anus, which means, like this picture, that infant has no anus. It's an imperforated anus. So this is a surgical emergency. Where's all of that fluid going to? We don't know. So this child is going to need a colostomy, and they don't have an anus, so they will have a colostomy for life. And then just know that as we're watching these infants, stool and, urinate, looking at their diapers, I've actually seen stools coming out of the vagina or urine coming out of the vagina, and these are fistulas. So just to be aware that these things can happen, to make sure that proper fluids are coming out of the proper body parts. Celiac disease. Celiac is, the inability to absorb because it's gluten. It has to do with fat. These children need to be on a gluten-free diet. These children, can live a normal life, but they can't have wheat and rye and barley. They have to have rice, and so no breads and cakes and stuff. But what's great today is even Publix has gluten-free everything now. Think about 30 years ago, they didn't make it like that. So it's more difficult for these children. Remember, they don't absorb fat. So one of the things that we need to do is, these children are small. They require secondary vitamins to help them keep their diet and keep their fat vitamins. Now, short bowel syndrome. It's like, what is a short bowel? Well, let's say you had a situation where a piece of bowel had to be removed. Now, I had one little twin came in for her second stage surgery. Her name was Jessica, and she was on a ventilator, and they were feeding her because they're just about to take her off. And I noticed the belly got huge and large. Well, basically what she had was what we called a necrotizing endocolitis. A part of her bowel died, but it wasn't just a part. It was 58 centimeters of her small intestines. So that's 58 centimeters of intestines that is not absorbing food. So this girl went home. She had a central line in. She got hyperalin lipids at night. She had a G-tube in. She got feeding during the day, but she was a tiny little thing because, and orally, she didn't take a lot. In the end, I met her, actually it was the day I left working at the hospital. She came back in, her and her, she's a triplet, came in to see me. And she still was very, very thin, but even with this poor nutrition, this girl lived through this hyperalin lipids and the G-tube because of a short bowel syndrome. Our biggest concern is nutrition. Is she getting enough nutrition? So necrotizing endocolitis is when a part of the bowel dies. Many times it's due to hypoxic episodes or feeding too much too quick, those things. Gastroschisis. Gastroschisis is when you're born, the midline of the abdomen closes and everything goes inside. Well, gastroschisis, the stomach is left on the outside. So the abdomen didn't close. So on top, you will see, instead of an umbilicus there, you'll see this stomach sitting out there. And what we do is just very slowly, we'll push it back in. The surgeons do it and we're able to close it up. I mean, it's still a stomach, it still works. You know, they even have the bladder on the outside. It's okay. They still work. They're still performing the same way. We just need to get them back inside. We need to keep it clean, sterile, prevent infection. Children love to eat everything, right? Anything they find on the floor. As I said, oral, oral, oral. The most common thing they like to eat is their vitamins. You know, if they're not with iron in there, there's really not a big deal. But I've actually seen them eat rat poison. And rat poison is literally like Coumadin. It's something that causes blood problems. I've also seen Tylenol. They like to eat those little chewable Tylenols. Of course, we know Tylenol, we could go into a liver failure. So depending on what it is. Now, parents should be given, you know, the #2 poison control, because even as nurses in the triage area, we will triage the child, find out what they had, when they had it, do all of those assessment things, and then we'll call poison control. And poison control will tell us the most up-to-date treatment for that child, depending on what they ate. And that's that for today. That's our PowerPoint. A lot of stuff in GI and GU, a lot of things there. So who wants to win the Kahoots today? Sharon, you're going to do it today, right? There you go. Jordan, you're ready, right? Ashley, yeah? No, maybe? Sandra trying to look there like, yeah, maybe? Okay. Alexandria? Jessica's on TV again. What channel
Ready.
do I tune in? What channel do I tune in today? Oh, I think it's adorable. Don't worry. The little things don't bother me. So remember, I'm working on those case studies. Don't send me messages. If I need you, I will call upon you. I am getting those grades. I'll be doing that tomorrow and getting them all put in. That is my goal. Gonna beat Brent. Okay, we have a game. Here we go. We're gonna beat Brent. GIGU week 8, amazing. A multi-select. All the following are symptoms of dehydration in an infant, except all of them are signs of dehydration, except that increased urine output. We know it's decreased. You're going to have elevated heart rate, decreased blood pressure. They're going to be dry, pale, weak, lethargic. What else? I mean, dehydration, just think of signs and symptoms and go looking for it. Oh, we have some dancing going on today. Okay. What is priority treatment for a child with dehydration due to profuse vomiting? What do we do for vomiting? So when a child's vomiting, you are going to put them NPO, and fluids is priority. Absolutely fluids, because dehydration in children can be extremely serious. Come on, Brent. What is the treatment for an infant with diarrhea lasting for 4 days? You have an infant having diarrhea, 4 days. What are you going to do for this child? Diarrhea, you are going to give Pedialyte. We are not putting them on IV fluids, because diarrhea, if you continue giving fluids, what's going to happen? They're going to have fluids out their butt too. There's nothing to make it a stool. So Pedialyte, Gatorade, Powerade, and as I told you, a lactobacillus, some probiotic. And that's all you do for diarrhea, nothing else, unless they are lethargic, and then it's IV fluids.
Are infants able to drink Pedialyte?
Yes, they can. Oh, absolutely.
Okay. That's why I was
yes, they can.
confused.
Oh,
Okay.
that's a great question. No, maybe I should change that infant to something older.
Yeah, like if toddler was there, I definitely would have chose Pedialyte, but infant, I questioned
Okay.
if they could drink Pedialyte. That was my rationale, but okay, just checking.
No, that's a great question. Thank you. I will change that. I like that. You're right. What acid-base imbalance may you see with a child that's having profuse diarrhea? Okay, when you're having diarrhea, you're getting rid of alkaline, you're getting rid of base because of all of the nutrition enzymes in the small intestines. That's all base. That's you're getting rid of base. So you have only acid left. So it's metabolic acidosis. These are questions that I'm telling you are on your HESI, very similar. So I put them here throughout the this class, if you notice, for you to know them. A multi-select. If an infant is not past the meconium stool in the first 24 to 36 hours, what would you assess for? What are those things I told you? Meconium stool, there's no stools. They're constipated and they're just born. What conditions are we concerned about? So it's thyroid condition, and we know we need thyroid hormone as soon as they're born, or else cognitively they'll be extremely delayed. They need that hormone. Cystic fibrosis and Hirschsprung's, there's just that dead nerve in there, and there's no stool being able to pass. So good. Has nothing to do with electrolytes. Nothing. Deficiency of a vitamin D causes what? Well, when you think of vitamin D, think of bones, and vitamin D is good for good bone and joint health, okay? If you don't have it, it's called rickets, okay? Scurvy is those oranges. I remember that because pirates had to have oranges on the boat, so they got scurvy. I remember that from elementary school for some reason. What treatment can the nurse anticipate for a child unable to drink or eat anything with profuse vomiting and diarrhea? So if they can't eat, unable to eat or drink, you need IV fluids, period. Okay? Vomiting and diarrhea, unable to. That was the clue in that question. A multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? So we don't want complete bed rest. We want to do post-op care, out of bed, walking, ambulating, coughing, deep breathing. Of course, it's a ruptured appendix. It's infective, antibiotic, NG tube to keep that bowel empty because it's so irritable. And because it was this toxin put into the abdomen, we need to be checking that surgical site because these are the type of wounds that will dehiss on you. I've seen one dehiss on me. Uh-oh, Brent, coming after you. Uh-oh. Passage of urine, usually at night in children who should have voluntary bladder control, is called what? It's called enuresis. Now, I have this slide here. Let me explain a couple others. Epispadius and Hypospadias is in a male infant born where the urethra doesn't end at the tip of the penis. Epispadias is the hole is on the top in the middle of the penis. And Hypospadias, the hole is at the bottom of the penis. So they need to do surgery to put the hole back where it needs to go. These children cannot get a circumcision because they need that skin for that surgical repair. And we just talked about vesicoureteral reflux. That's between the bladder and the ureters. It's just reflux. It has nothing to do with bladder control. Uh-oh, Brent took over. What is Hirschsprung's disease? Well, we know it ends up with a colostomy. So that's what we call congenital absence of the ganglion cells. Ganglion cells is nerves, no nerves, it outpatches, it's dead bowel, needs to be removed. What type of stools would an infant with Hirschsprung's disease have? Remember, there's this big outpatching and it goes really tiny down to the anus. So what sort of stools may you have, if you have? And they're ribbon shaped because that tiny little opening, some stools can squeeze out of there. It's just like icing on one of those little things that you would decorate cakes with. It's that same sort of concept. Which is a condition that occurs mainly in children when the intestines telescope into itself. And it's called intussusception. Gastroesophageal reflux disease, GERD, what is that? What does it mean? It's when the stomach, the food goes up into the esophagus and it can cause problems like aspiration. Inflammatory bowel disease, IBS, involves what? It's any part of the intestines, mouth to anus, any part of them. What would the nurse be looking for when a patient has Meccal Diverticulum? It's that little piece at flower thing that rips and has a vessel inside of it. And it is painless rectal bleeding. And you'll see the bleeding, but it's painless. That's what makes it a Meccal. Twisting of the bowel, blocking the lumen in the intestines is called. And that's called a volvulus. And that's that twisting, whether in a knot or wrapping around something. They're very hard to diagnose. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority to know about? 24 hours been sick. What assessment is your priority here? And that's the pain. Where is the pain? Is it a appendix? Is it something else? And that could clue us into things that require, surgical intervention or medical intervention, according to where the pain is, you can tell. What would the nurse expect to see in an infant with biliary atresia? Well, remember you have biliary, which is, in the common bile duct, it goes into your gallbladder and your liver, and atresia means there's no openings there. So you're not getting these enzymes into the small bowel for digestion. So when we see this, it's, you could see that jaundice that comes on like that baby just had, because it's the liver, it's not draining, so it's going into the body. So you don't have the coloration from it. So you're going to see those clay colored stools. Also, what does the liver, the biliary secretions, the bile, what does it do for food? Well, it digests fat. You don't have fat, you can't digest it. There's your abdominal distension, okay? What structure of the mouth can be impacted by cleft lip and palate? And that's hard palate, soft palate, lip, one side, both sides, don't matter. What is the most common associated syndrome for cleft palate? There's a bunch of syndromes, that you could go over. I could go on forever about how many of them. I always open my mind to new ones that I do see. This is actually one that I've seen quite a bit in children. And actually, besides this, these children, with a cleft lip palate, they have issues with eating, and they actually grow out of it. And it's called Pierre-Robin syndrome or sequence. It's just Down syndrome, Pierre-Robin, DeGeorge. There's a bunch of different things, and they do different stuff, just to show you there are different things that can cause it. So a cleft lip repair is typically done when the lip the lip is done between 2 to 3 months. The palate is done later, usually 6 to 12 months. Actually, I like to get it before they start to talk, so they don't have those speech issues. When does a cleft palate repair typically occur? And that's usually 6 to 8, 12 months, somewhere in there. But it's usually, as I said, it's before they try to start talking. And it's usually about 1 year old. Esophageal atresia. Esophageal atresia. Well, esophagus, atresia without, no opening. So no opening to the esophagus, to the stomach, and it's done. This is, you find out at birth. And usually you find out because they're spitting and coughing and gagging because they're aspirating. What are the classic signs of esophageal atresia and tracheoesophageal fistula? And as I said, you can't deal with the secretions in your mouth. So you'll see them turning blue and choking and coughing because they're aspirating. Now, this current jelly stools, failure to thrive, abdominal pain, that is intussusception. The olive-shaped mass, right upper quadrant, that is your pyloric stenosis. Pyloric, and then the bilious emesis could be many different things there. But that was 3 different diagnoses. You got symptoms. Neonate with suspected tracheoesophageal fistula. The nursing care should include what? So we have that hole going from the trachea to the esophagus. And we know we're concerned about putting food in there and going into the trachea and secretions going in there and causing aspiration. So what do? Well, we're not feeding this child because it's going to go directly in the lungs. So keep the head of the bed elevated, make them NPO. This child, until they decide what to do, is going to have IV fluids and hyperalimentation and lipids as it goes forward. A 5-year-old's complaining of epigastric pain and a persistent cough. What would you suspect? And it is a gastroesophageal reflux. It's one of the things that we'll see is that cough means they're aspirating and the cough is telling you they need to do something. Signs of hypertrophic pyloric stenosis is, well, we know there's projectile vomiting. That's one of them. And it's that olive size mass at the midline. Remember the pyloric valve gets thickened and muscular, and you can actually feel it there. Once I know they're vomiting and it's projectile, it's the next thing that I'm going to look for. Signs and symptoms of hypertrophic pyloric stenosis. And it's projectile vomiting. Now, some people thought maybe it was also poor appetite. Well, if you are eating and you're vomiting all your food, you're not going to have a poor appetite. You're hungry. You want more and more and more. So you are chronically crying because you are hungry, not because of a poor appetite. What does celiac disease affect? And it's the small intestines, that's all it is, okay? Celiac disease is the small intestines, and this is where all of your enzymes are done for absorption, and all the villi in the small intestines are there. And if we're eating the wrong things, that's when the bowel goes into spasm and causes severe pain, for whether it's a child or it's an adult. If you have celiac disease, what should you eliminate from your diet? No wheat, no rye, no barley, but you can have, a lot of different things on this diet. It's just something that you have to become creative. I know one of my nurses I worked with, son had it, and whenever they had special events at school, he would bring, a gluten-free cupcake or something for his kid. So he never felt like he was missing anything. A multi-select. Vitamins that children with celiac disease are prone to lose are Well, what sort of vitamins are they prone to lose? Well, they don't digest fat, right? So which one of these are fat? Is A, D, and K. Vitamin C is water soluble. It's the other three. And Sandra's beating Brent now. What foods would you select for a child with celiac disease? Well, if you look at what they can't have oats and rye and barley. So anything with bread, you can't have. So no macaroni and cheese, those are noodles. French toast is bread, and garlic bread, no. But they can have eggs and bacon, bananas, dairy, cheese, all of that they can have. So yes, that is the answer. Phimosis, what is that? Phimosis is when the foreskin gets so tight that you can't pull it down over the penis. Many times these children will urinate and the skin will get big and then it will squirt out the end. My grandson at birth, his skin was so tight, it was actually pinching the end of his penis and we couldn't get it down. So at 1 month, he had to get the circumcision because he had severe phimosis. Because treatment is every day you should pull it down and clean it, but we couldn't. What is a hydrocele? I mean, usually if you have this, you're going to probably, usually you're incontinent of urine is what usually happens, which says this isn't normal, what happened? And it's an infection treated with antibiotics, but it's just fluid that goes around the testes and it irritates it and it causes water, hydro causes water there. And it's painful. What is cryptorchidism? So cryptorchidism is when a male infant testicles are not in the scrotum, they're not in the sac. One or both could be up. Now, the way to check for this is number one, we know that if it's cold, the testicles shrink up, right? So if we're going to examine this, the room needs to be warm, okay? So you're getting an accurate information, accurate assessment. So if they're not both down, you have either one or two, could be, with cryptorchidism. What do we do? Well, sometimes they have to do surgery to bring it down because the testicles do not like heat. So it could kill the testicle, which is, part of being able to have a child. So they want to get that down and protect that testicle. You suspect an infant has a cryptorchidism. How would you examine this infant? Shake them down, make sure it comes down, right? And you just put them in a warm room, okay? So put them in a warm room, pull the diaper, look at it and feel them. And if they're there, you're good. If not, then you have an accurate assessment. A hypospadias. Mentioned it earlier with another question. You need to know what dorsal and ventral is. So ventral is the underside of the penis. In the middle of the penis, the urethra is there instead at the end of the penis. Now, how do they fix this? So they about 8 months, usually before they're potty trained is the great time to do it because they need to have penis working correctly. So they'll take the foreskin, use it, do a surgical repair, cover the hole, and bring it out the end. Now, they basically make the lumen inside the penis. So what they'll do is they actually take the straight catheter that you'll use a female or an infant with, they will put it in there, okay, and send them home with it. And we don't do anything with it, okay? We don't flush it, we don't touch it. All it's there is to keep that lumen opening. And then of course, keep that tube within the diaper because they will be urinating through that. And they actually do very well with it. One of the diagnoses for that actually is Pierre-Robin also can have this hypospadias. A multi-select. How is the hypospadias corrected? So they use the foreskin and they put the stent in. It is done under general anesthesia. This hurts. This is a big manipulation. This is, making a new hole at the end of the penis and constructing, this inside so that we can have the urine flowing, out the end where it should. And Brent's back up on top. What is a bladder exstrophy? It's like a gastroschisis. I said you'll see one or the other. Now, it doesn't mean the bladder doesn't work. It still does. And what it is the bladder, when it closed, the bladder stayed up top. So there's an opening in the abdominal wall and the bladder's sitting there. Now, it's still urinating, it's still holding urine, it's still, the baby still urinates the same way. It's just their bladder is out. Our goal is to protect that bladder and prevent it from having infections. So we'll cover that with a dry, sterile towel or something to keep it as clean as we possibly can. Uh-oh, Sandra's up again. What are the clinical manifestations of nephrotic syndrome? And it's hypoalbuminemia, peripheral edema, proteinuria, low serum albumin. Very good. Remember, nothing to do with renal failure, nothing. Children with nephrotic syndrome are often given which medications for fluid overload? So you've got all of this extracellular fluid, this swelling, this edema. How are you going to pull it into the body, into the blood system and get rid of it? Well, we'll give them that protein. So it brings it back into the cells, into the bloodstream, then give them some Lasix behind it, and then you're getting rid of a lot of that fluid. Very good. Actually, you give them 25% albumin. There's 5%, 25. We want to give them the super potent protein one. What is used to treat nephrotic syndrome in children? And you would say with all the swelling, we're going to give that. And that's exactly what we give. And it is prednisone. When you're thinking prednisone, one of the side effects is weight gain, but it is what we use with it. It's like, why? It works. What is the priority nursing care for a child with nephrotic syndrome? Priority is monitoring daily weights, intake, output, fluid restrictions, and decreased salt. Very good. Why is erythropoietin used in chronic kidney failure? It's because chronic kidney failure, you always have high potassiums, low hemoglobin hematocrits. So this helps the body produce red blood cells, preventing maybe a blood transfusion. A multi-select. Children with CKD, chronic kidney disease, have renal osteodystrophy. What can this do to the child? Osteodystrophy, osteo bone, dystrophy means not proper, right? A problem with it. And, you know, we're talking calcium, so that's your parathyroid thing that's going on too much, but the bones aren't forming correctly. So skeletal abnormalities, and of course, if they're not forming correctly, you're going to have a smaller child. They're not going to be as tall as they should be. And going to beat Brent, just went on top. A diagnostic finding of acute glomerular nephritis may be so this positive anti-streptolysin titer, I put that there because ASO titer sometimes is one of the way that they'll mention strep throat. Anti-streptolysin, it's strep. It's all about the strep. It's another way of saying they have a strep throat or have had one in the last 3 weeks. Uh-oh, Brent went back up. Which complication of peritoneal dialysis is most important? Most important. And that's taking care of that belly, abdominal peritonitis. If you don't have an abdomen, who's going to do the work of the kidney? So we need to keep it infection-free. Uh-oh, you guys are fighting. What clinical assessment is most important to report with a child diagnosed with acute kidney trauma? You know what it is? Potassium. You know, I actually saw one kid, they were out playing tag or one of those games, and they were in the backyard, and there was a trailer with a hitch. And he came around the corner backwards pretty fast, and his back area right by the kidney hit the hitch. And he came in with this huge bruise. His potassium was like 7 point something. And I was surprised to see that. So kidney trauma, you will see that potassium elevated. So you know the severity of that trauma just by the potassium. Multi-select. What should the nurse anticipate for a child who just had a renal biopsy? So intake and output, making sure that, you know, the urine's going to the right place, monitor that dressing, make sure it's not saturated, and we're going to keep them on bed rest. Absolutely not out of bed for 24 hours. They're sort of similar in the way that we look at them like cardiac cath, same sort of nursing care. What would you do if the fluid draining from peritoneal dialysis has changed color and it's now cloudy? 2 more questions. Immediately call the doctor because we need to get antibiotics ordered. I've seen students say, no, I'm just going to give antibiotics. Well, what's the order? There's not a standing order for it. It's something you'd have to call the doctor and get it. Uh-oh, Brent, last question. What would the nurse provide to an infant that cannot eat normally? They can't eat by mouth. They have TE fistula. So if they can't eat normally, remember infants need that stress reducer, that oral satisfaction. So they need to have that non-nutritive sucking, that pacifier. It's that comfort driver. So let's see how we did now. Number 3, Sandra. Good job, Sandra. I told you you'd beat her. Number 2, uh-oh, she did it, Brent. Whoop, 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 whoop. Gotta beat Brent, and you did. Cody and Jordan. Good job, guys. I like to see a fight. I do. Anyway, guys, please sign your attendance attestations so you don't forget to do that. I'm in the process of doing your discussion questions, so they will be done also. Any questions, anything you need, let me know. Get those projects to me and I can tell you if there needs to be any changes so that you can get your best grade you possibly can, okay? Thank you, everybody.
Do you want us to turn them in and then you give us feedback, or do you want us to email them?
No, you can turn you can turn them in because you can do multiple submissions, okay?
Okay, awesome, thank you.
So you can keep putting them in as many times as you want. That's the way I made it, okay? Good job, Brent. Good job. I want to beat Brent. Take care.